Shall we good to go?
Welcome all attendees of the ACP India chapter. We are welcoming you for the first time in this year 2022 for a very innovative idea of CMEs, and this virtual CME and webinar CME has given us opportunity to talk about many untouched topics, and gender inequality is one of those. Gender inequality is really a very important but less talked area, especially in the medical science. We talk about the gender inequality in the social perspective. I was seeing a few months before that gender equality ratio in India is 0.66667. So such a bad gender equality data, or just such a bad gender equality situation in our country is there. In such situation, how can we really handle the treatment part, especially the diseases which are concerned with the women, which are specific to the women, and especially many times I say that when a man gets heart attack, people go for the cardiologist. When a man has in his home chest pain, people search for the cardiologist. But if the same thing happens to a woman, people look for the lady doctor. So this kind of the approach should change, not only from society, but also from the healthcare world too. So in keeping all these things in the perspective, we are touching today two very important topics, endocrine as well as the rheumatology. In endocrine, we are having a vast area of the gender inequality. We are having a lot of issues in which we have to face gender inequality, especially we are bound to go with that kind of the gender inequality. Dr. Usha Shriram shall be taking up that session. After that, Dr. Vinod Ravindran shall be taking up the similar kind of the gender differences in rheumatological issues. Finally, Foxy President Dr. S. Shantakumari shall be talking about the violence against the women, which is also very much important as far as the all developing countries perspective is concerned. So with these words, I will invite Dr. Jk Sharma. Dr. Jk Sharma is the person who has given this idea for the first, that we should have a session on the gender inequality. Dr. Jk Sharma is Vice President of ACP India chapter. He is a wonderful visionary for many people practicing medicine in India. He is also very holding a very key position of the Innovative Physicians Forum as well as in the Royal College of Physicians. He is visiting professor of faculty, Department of the Medicine in JN Medical College, KLE Academy of the Higher Education and Research, Karnataka. He has been conferred DSc by HNBU Medical Education University of the Uttarakhand. He is an honorary professor of the IMA headquarters, fellow of American College of Endocrinology, fellow of all four Royal Colleges of the Physician, London, Edinburgh, Glasgow, and Ireland, international advisor for the Royal College of Physician of Edinburgh, North and Central India, President IMA Karol Bagh branch, Vice President of the ACP India chapter, I have already told. And in fact, he is the person who have recommended me for the Royal College of the Physician Edinburgh. So he is a very senior person and very reputed as very visionary individual. So I shall be asking him to give his idea, because he was the initiator of this kind of the program. So I will request him to give his idea about gender equality or gender inequality, what is in his mind on this aspect, and why did he suggest to design such kind of the program. Obviously, this is a very good and very useful and very much required, but we shall be looking forward to listen Dr. Jk Sharma for the same. And after that, he will be moderating the session till the end. Over to Dr. Jk Sharma.
Thank you, Professor Anuj, for the nice words. And as the topic has very well been introduced by him, it came to my mind when we were discussing about what should be the next topic for this webinar, and then it came to my mind that why not we talk about the gender inequality or the gender equality. Dear friends, there is a very important, yes. I will just share my screen and then go about this.
Welcome, Dr. Usha Shriram. I think you are muted.
Yes.
So is my slide visible?
Not yet, sir.
Okay. Just give me half a minute, I'll do it.
Why so long?
Just 1 second.
You just click the share screen, green button in your screen.
Yeah, that I'm doing. See, basic files. No. I have just changed my laptop, so that is a little.
सर ऑन योर स्क्रीन आपको ग्रीन कलर का बटन दिख रहा है?
हाँ, ग्रीन बटन दिख रहा है मेरे को।
सर उस पर क्लिक कीजिए, देन आपको मल्टीपल ऑप्शंस आएंगे विंडोज के, उसमें से आप अपना पीपीटी सिलेक्ट कीजिए एंड देन शेयर कीजिए।
एक सेकंड,
इसको बंद करें एक बार, इसको बंद करें। Share screen.
but it is already granted access.
Just a second. What should I do? Let me
It is
first.
not granting access.
सर फर्स्ट यू हैव क्लिक ऑन ग्रीन कलर आइकन शेयर स्क्रीन,
Right. Then it is.
हाँ आपको मल्टीपल्स ऑप्शन आ रहे होंगे जिसमें से एक आपका पीपीटी का होगा, आपको दिख रहा होगा व्हाइट बोर्ड, विंडोज एंड ऑल
Yes.
थिंग्स। तो उसमें से आप अपना पीपीटी सिलेक्ट कीजिए,
Sure.
देन नीचे छोटा सा बटन होगा शेयर करके, वहां पे क्लिक कीजिए, वो सिलेक्ट करके फिर वो शेयर बटन को क्लिक कीजिए।
पीपीटी सेलेक्ट नहीं हो रहा ना, एक सेकंड। सिस्टम प्रेफरेंसेस।
Or you could open up your PPT and then minimize and then go to share screen and share the screen, Doctor.
I think I will have to quit and rejoin.
Sir, you can mail your PPT to me so I can share from mine.
Okay.
Just 1 second. इसको minimize करो पहले। बंद कर।
What is the email ID?
I don't know the email ID. Tell me your email ID.
RX event.
Sir, nirav@rxevents.co.in. Also, I can enter in the chat box.
Nirav.
Nirav, NIRAV @rxevents.co.in.
At rxevents.
.co.in, sir.
Have you received?
No, sir, not yet.
Wait, Google Chrome, can you just close this?
Have you received it now?
Yes, sir. Just a second. I will share it.
Oh,
Now I can also share it. So you don't share, I have already shared. Can you see my screen?
Yes, sir. Just make it in presentation.
All right. Is it okay
It's
now?
okay. Yes, yes, sir. It is okay. Please go
Okay.
ahead.
Sorry for the significant delay.
No problem. You can go ahead.
Amriti? Let's go, move. Okay. So the topic has already been introduced by Dr. Anuj, and now I will take you through this. Gender differences in determinants and consequences of health and illness. Dear friends, first we have to understand what do we mean by gender and what do we mean by sex. Gender refers to the area of socially constructed roles and relationships, the personality traits, attitudes, behaviors, values, relative power and influence that the society ascribes to the two sexes on a differential basis. And it is relational. Gender roles and characteristics do not exist in isolation, but are defined in relation to one another and through the relationship between women and men, girls and boys. But when we simply put, sex refers to biological differences, whereas gender refers to social differences. Now, there are 3-4 important terms which we have to understand. Health, we already know, defined by WHO as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, it can influence an individual's ability to reach his or her full potential in the society. Gender equality, gender inequality, the health inequality, health disparities, and health inequity. When we talk of the gender equality, it has made the most progress in areas such as the education and labor force participation. Inequality between men and women continues to harm many societies of this day. While both male and female face health disparities, women have historically experienced a disproportionate amount of health inequity. In the next slides, I will be telling you what is inequality, what is inequity. This stems from the fact that many cultural ideologies and practices have created a structural patriarchal society where women are vulnerable to abuse and mistreatment, and females are also frequently underrepresented or excluded from the mixed sex clinical trials and therefore subjected to physician bias in diagnosis and treatment. Now, what is health disparity? It has again been described and defined by WHO as the differences in health care received by different groups of people that are not only unnecessary and avoidable, but also unjust and prejudiced. The existence of health disparity implies that health equity does not exist in many parts of the world. So equity in health, which refers to the situation whereby every individual has a fair opportunity to attain their full health potential, and that is equity in health. So overall, the term health disparities or the health inequalities is widely understood as the differences in health between people who are situated in different positions in a socio-economic hierarchy. And here you can very well see what is equality versus equity. In the first image, we can see that it is assumed that everyone will benefit from the same support. Equal support has been provided to all the three individuals and they are being treated equally. In the middle picture, if you see, individuals are given different supports to make it possible for them to have equal access to the game. They are being treated equitably. And in the third picture, we can see that all three can see the game without any support or accommodations because cause of the inequity was addressed. The systemic barrier has been removed. And again, here you can see that inequality, unequal access to the opportunities, which is shown in the first picture. Then the equality, evenly distributed tools and assistance, which you can see on both the sides, and custom tools that identify and address the inequality is the equity. We will not talk about justice at the present time. Now, gender inequality, what is the data? 1 in 5 girls is married before turning 18. The 1 in 4 girls out of secondary school, only up to secondary school. Over 800 women and girls die in childbirth every day. Total number of women and girls subjected to harmful practices like female genital mutilation and child marriage is still growing. Total number of women with an unmet need for contraception is still growing. So half of the women in low middle income countries have no decision-making power over their own bodies. The gender differences in determination of health and illness, and these determinants, we can say that they are social, they are economic and biological determinants of health and illnesses. And if we take the example of these 3 non-communicable diseases or conditions like nutrition for social determinants, mental illnesses for economic determinants, and longevity for biological determinants, we can find out that the various social factors, the degree to which the women are subjected in schooling or from participation in public life, affect the knowledge about health problems and how to prevent and treat them. The example of nutrition will demonstrate how gender has an important influence on the social determinants of food consumption pattern and hence on health outcomes. We all know that there is a positive relationship among education of mothers, household autonomy, and the nutritional status of their children. So in some countries, especially in South Asia, men and boys often receive greater quantities of higher quality nutritious food such as dairy product because they will become the breadwinners. Depriving female children of food was an explicit strategy used by parents to achieve a small family size and desired composition. Now, when we talk of the economic determinants, they are productive labor, reproductive labor. Productive labor, usually defined as labor performed outside the household in income-generating employment. And the reproductive labor, which includes work done within the household, like food preparation, child care, housework, care of the livestock, and kitchen gardens. Reproductive labor, in addition to reproducing the daily conditions of domestic survival, also assures the reproduction of human values, attitude, and culture. And this is being looked after by the female gender. In both industrialized and developing countries, women spend considerably more time than men in reproductive, volunteer, and other unpaid labor, whereas men spend significantly more time in productive, remunerated work. When we talk of the biological determinants of health and illness, the differential genetic vulnerability to illness, reproductive and hormonal factors, and differences in physiological characteristics during the life cycle. We all know that until recently, a male model of health was used almost exclusively for clinical research, and the findings were generalized to women, except for the reproductive period. Clinical trials typically excluded women to protect them and their unborn children from possible negative effects. Now, coming to the gender differences in consequences. So what are the consequences of these determinants? How gender affects the social, economic, and biological consequences of health and illness. Again, we can focus as an example of the 3 non-communicable diseases or the condition like diabetes for social consequences, domestic violence for economic consequences, which will be taken up by Dr. Shanta, and occupational health for biological consequences. We will take one of them. The gender differences in the social consequences of health and illness. They include how illness affects men and women, including health-seeking behavior, availability of support network, and the stigma associated with illness and the disease. Men and women respond differently when ill in terms of time before acknowledging that they are ill, recovery time, and how women and men are treated by their families and society. And this is a very, very strong factor that if we all have seen in this COVID era also, that in a family of 4, if all 4 are ill, they are suffering from COVID, the responsibility for the reproductive labor in the family comes with the female gender. And this is really alarming. Men seek treatment more frequently at formal health service, whereas women are more likely to self-treat or use alternative therapies. The gender difference in the economic consequences, they include how work of men and women is affected by illness, such as availability of substitute labor, opportunity cost of health-related action, available income, and the impact of economic policies. When men are ill, others encourage them to seek medical help, and hence they are appropriately diagnosed and treated earlier than women. They also receive greater care from wives and others and are not expected to perform other duties until they are better. Women often substitute for their husband in agriculture work when they are ill, but husbands rarely substitute for their wives. Men are more vulnerable to major life-threatening chronic diseases like coronary artery disease, cancer, cerebrovascular disease, emphysema, cirrhosis of the liver, kidney disease, and atherosclerosis. Women suffer more from chronic disorders such as anemia, thyroid, gallbladder condition, migraine, arthritis, colitis, and eczema. The biological advantage of women appears to be related to their ability to bear children and the physiological systems that permit pregnancy and childbearing, whereas men's health advantage seem to be due to lower level of role stress, role conflict, and lower social demands. So very important now is the gender bias and diagnosis. In 2018, literature review of 77 medical articles found gender bias in the patient-provider encounter as related to pain. And when we see in women with pain were viewed as hysterical, emotional, complaining, not wanting to get better, malingering, and fabricating the pain as if it is all in her head. And when women suffering with chronic pain, they are often erroneously attributed to psychological rather than somatic causes for their pain by physicians. And in searching for the effect on pain medication given to men and women, studies determined that women received less effective pain relief, less opioid pain medication, more antidepressants, and more psychiatric referrals. Now, I come to my last presentation slide, gender bias in clinical trials, which is again a very, very important factor. In 1993, the US FDA published guidelines for the study of evaluation of gender differences in the clinical evaluation of drugs. And through this, they recommended that women be included in clinical trials to explore differences in the sexes, specifying that the population included in clinical trials should be indicative of the population to whom the drug would be prescribed. And the National Institute of Health presentation of safety and effectiveness data for certain subgroup of the population in investigational new drug application reports and new drug applications. Regulations mandated that drug trial prove safety and efficacy in both sexes in order to gain FDA approval, and led to the drugs being taken off the market due to adverse effect on women that had not been appropriately studied during the clinical trials. So this is very, very important. But friends, when we talk about our own healthcare, if you look at this, Association of American Medical Colleges, they summarized in their executive summary. Look at this, the representation of women in academic medicine 2018-2019, medical school applicants 51% females. Medical school graduates 48%, residents 46%, faculty 41%, division chiefs only 29%, full professors 25%, senior associate deans 34%. But when we come to the deans, they are only 18%. So 18% of the deans in the medical colleges are women. So even this gender inequalities is there in our medical profession as well. So with this, I invite our chairperson to chair the next session, which will be delivered by Dr. Usha Sriram. And I think I have told you what we are looking for and how we'll go about that. So with this, I stop sharing my slides and I invite the chairperson, Dr. Padmasri Gulati. Dr. Padmasri Gulati is senior physician and diabetologist consultant attached to District Railway Hospital at Jhansi, and she has her Gulati Medical Center, where she is the senior consultant. She is fellow of American College of Physicians and fellow of the UP Diabetes Association. And I invite Dr. Padmasree Gulati to introduce our speaker for the next talk.
Thank you. Thank you, Dr. Sharma. Good evening, all. At the outset, I would like to thank the ACP Governor, Dr. Anuj Maheshwari, for inviting me as faculty for such an interesting webinar on gender inequality being held under the aegis of ACP India chapter. So the stage has already been set up by Dr. Sharma, who so explicitly spoke about the gender determinants and consequences in health and illness. And as we all know, gender-related differences, they represent a new frontier towards patient-tailored medicine. So over the last decade, increasing attention has been paid to understand the influence of gender on pathogenesis of diseases and clinical response to treatment. And amongst the medical disciplines, endocrinology is probably the one that falls in issues concerning gender medicine. It's not only the sex hormones, but also the gender that is responsible for the differences in the human endocrine system. So now we begin with the first session on gender intricacies while managing endocrine diseases for 20 minutes. And for this, we have an eminent speaker, Dr. Usha Sriram from DHS Hospital in Chennai. She's an American board certified endocrinologist and diabetologist from Chennai. Her education in medicine began in the prestigious Madras Medical College, where she excelled in academics, garnering gold medals and certificates of honor. She is a founder director of Acer Health and founder of Divas. She is an egalitarian, strongly advocating and promoting women's health and women's rights. And I'm deeply honored to be chairing the session. Over to you, ma'am, Dr. Usha Sriram.
Thank you so much, Dr. Gulati. And first, again, I want to thank Dr. Anuj Maheshwari for this very kind invitation and also to shine the light on such an important topic. And as you said, Dr. Sharma has very nicely set the stage for this evening and explained the difference between sex and gender and the importance, the difference between equality and equity and really important concepts. So let me start by first sharing my screen and then we can discuss. I hope you can see it, right? Okay.
Yes, ma'am.
So, thank you so much. So the topic given to me is gender intricacies in managing endocrine disorders. And as Dr. Gulati said, there is no other specialty in medicine where I think there is this, the interplay of sex and hormones and gender and health, as in endocrinology and metabolism, which includes diabetes. So my overview is going to be on very briefly on gender as a determinant of health and some specific disorders that we look at. There are many, but I'm just going to pick a few just to highlight how, again, gender is a determinant of health on the one hand. And also, again, as Dr. Sharma said, we are now gone into the space of personalized medicine and precision health. And if we don't include gender in the way we approach a patient, I think we will be doing them a disservice. So it's very interesting that Dr. Anuj asked me to speak on this topic because just in the most recent issue of the Indian Journal of Endocrinology and Metabolism, I was asked to write an editorial on applying a women's health lens to endocrine and metabolic disorders. So I'm really thrilled. And I just wanted to mention the theme for International Women's Day 2021, and I know 2022 Women's Day is coming up, was choose to challenge. And a challenged world is a very, obviously a more aware world. And I think dismissing gender inequality should be one of the important challenges that we have. Not only are we going to talk about applying gender, we also have to look at the existing gender gap, which is, nowhere I really think is seen as much as in in research and how we approach women. And I think this picture just to show you the gender gap. So very quickly, a couple of interesting differences. This whole biologic sex is for humans, non-human animals, primates, and typically binary, male, female. Whereas if you take gender, it's unique to humans, it's multifaceted and complex, it exists on a continuum. And then, with sex, it's determined by chromosomes and physiology and hormones and gene expression, whereas gender is determined largely by social, cultural, psychological, political behavior and other roles, and can change over time. But I want to highlight something here. What COVID has done to women's health is push more women into poverty. I think there is going to be, I don't want to use the word pandemic, but a tsunami of non-communicable diseases that's going to happen, and other health issues. And whatever progress we have made in women's health, I think is going to be rolled back thanks to lack of funding and deprioritizing. And I think this cartoon very nicely shows what COVID has done to non-communicable diseases, maternal and child health, and other infections like TB, malaria, and HIV, which we are already beginning to see the impact of. And no one is more affected by all of this than women. And when we talk about the social determinants of health, if you really see here, whether it's education or income or employment or access to health services, we all know that women are the one more affected, more vulnerable group. And this extends to the endocrine and metabolic disorders as well. Even when during the development of the female and male sex, and you can see the development of the female sex is typically more like a default development. No Mullerian inhibitory factor, no testosterone, and then there is a default development. So I'm going to take a few issues that we deal with on a regular basis, and nothing, because the diabetes is on the rise and on the rise. And first thing I want to talk about is, though we hear about numbers that there's more men have diabetes, the truth is the lifetime risk of diabetes is higher in women in our country and globally. And that's very important to keep in mind. The drivers of diabetes, while things like urbanization, globalization, obesity, sedentary lifestyle are the same for men and women, we also know there's more obesity in women, but things like pregnancy, GDM, PCOS, which increases the risk by 4 to 7-fold, menopause, all of these things are uniquely for women, and they're all drivers of diabetes. And on this side, when we look at things like caregiving, which is typically a women's domain, so to speak, is a risk factor for developing diabetes and other NCDs. And poverty, even in our own country, more women are poor, and the poor are developing more diabetes. And all this applies to stress as well. When it comes to genetics, when a mother has diabetes, her daughter has a greater chance of both GDM and type 2 diabetes. There are both physiologic and big pathologic sex differences when it comes to obesity and glucose metabolism and insulin resistance, and all this applies towards the diagnosis of diabetes. But there are also other things like household air pollution, which again is a driver of diabetes. But what is the most striking difference is the complications are much more and more deadly in women. Coronary artery disease, stroke, vascular dementia, chronic kidney disease, the more the progression to end-stage renal disease, and more recently, 27% more cancer in women with diabetes, whereas 19% more in men with diabetes. And why this is important is, if we are going to apply the gender lens and really be equitable in their care, we need to pay greater attention to women for their CV risk factors or other complication-related risk factors and heighten the surveillance. And also, not just the complications, mortality is higher in women across most of the continents, except in North America. Most of the IDF regions, more women die of diabetes. And why is that? As I mentioned earlier, cardiovascular disease. And you can see it's not just coronary artery disease, it's heart failure and many other reasons as well. And they also don't do so well after revascularization procedures. Their chance of recurrent MIs are higher. One important factor that I want to mention is even gestational diabetes is now linked with increased risk of cardiovascular disease, not because of type 2 diabetes, just on the basis of GDM itself. So we need to highlight this. And when we look at cardiovascular risk factors in women, and we're talking about diabetes, but also look and see there are GDM, hypertensive disorders of pregnancy, preterm delivery, PCOS, premature menopause, psychosocial aspects. We're going to hear about partner violence and other abuse. Those are all now risk factors for cardiovascular disease, and we need to acknowledge that. And on top of that, when women come for care, they're not provided, less likely to have the test, angiography, exercise, ECG. So these play a part. Let me summarize this in this slide. When men and women, from the time they get from normal glucose tolerance to go to pre-diabetes and diabetes, takes a little longer for women, and it may take a little longer to get diagnosed as well. And then they may have more inadequate risk factor screening and preventions, both primary prevention and secondary prevention for complications may not be begun as early or done as aggressively as women, and also pharmacological interventions. So these are really important gender differences that we healthcare providers, we are responsible for that. So that is about diabetes. Moving to thyroid and parathyroid, January is Thyroid Awareness Month. So I just want to say that thyroid disorders are so many fold higher in women, 8 to 10 times higher in women. And therefore, this is very important that we talk about it today. Very quickly, I just want to mention the prevalence is higher in women, autoimmunity is higher, and implications for reproductive function is higher. And when people have hypothyroidism, there is also hyperprolactinemia, which again can have implications for women in terms of both their menstrual history and also their reproductive function. And preconception care becomes very important because we know that we apply a completely different set of rules for thyroid when it comes to women who are planning a pregnancy or who are pregnant. Pregnancy losses are higher in subclinical hypothyroidism and hypothyroidism, gestational hypertension, and GDM are higher in people with subclinical hypothyroidism and hypothyroidism. And bone health is affected in women, especially women who are on replacement. And if they're over replaced, they can have bone loss in the postmenopausal years. And so we have to be very, very careful. And you can see all kinds of thyroid disorders are more in women. So I mentioned the intricacies. When it comes to hypothyroidism, obviously, especially if they are in their reproductive age group, we need to keep their TSH below 2.5. We need to treat subclinical hypothyroidism in women, but in women, the subclinical hypothyroidism throws up another issue because obesity itself increases TSH level, and we know more women are obese. And when it comes to hyperthyroidism, I already mentioned we have to take into account reproductive history because pregnancy losses are much higher in people with hyperthyroidism. So these are, and even thyroid nodules and cancer are higher. Autoimmunity is the main reason, and we know that women are more prone to autoimmune disorders. And the BMI issue, when the BMI is higher, the TSH tends to be higher. And this is something to keep in mind, and not jump and treat every woman whose TSH is mildly elevated simply because it's elevated or she's overweight. And only those who are planning a pregnancy or who are pregnant should be treated for even subclinical hypothyroidism. The others, I think we should work on their weight. And very quickly, I just want to say that how we approach the TSH elevation has changed now because of newer guidelines. And as you can see, we want to keep it below 2.5. And even those who are between 2.5 and 4, we want to get anti-TPO antibodies and then make our decision based on that. So this is very important that in women, we have a very narrow range where we want to keep the TSH, especially the women, only the women in reproductive age group. And as I mentioned before, prolactin is an important important hormone to consider in women with hypothyroidism or subclinical hypothyroidism, and how we evaluate them. And I just want to even talk about prolactin itself. Prolactin is a hormone that is, made by the pituitary and primarily responsible for lactation. But when the levels go up, it has other implications. There may be galactorrhea, there may be amenorrhea, and because of the hypoestrogenism, it can also lead to bone loss. It's also known to increase rank ligand. So, but prolactin can go up not just because there is a pituitary tumor, but it can be because medications, something like proton pump inhibitors or antipsychotic medications, and it can be because of hypothyroidism, and it can be because of certain other medical conditions. So when a woman presents with amenorrhea or galactorrhea, and we want to work them up, we want to make sure that we go through a complete medical history and make sure the simple things are ruled out before we jump and do an MRI on them, because we know that MRIs nowadays can have incidentalomas, and we may be picking up a small tumor, calling it a prolactinoma, when really the prolactin is high because the patient took proton pump inhibitors. Couple of very interesting things about thyroid and women. Like I said, we can induce amenorrhea. It can also induce precocious puberty, and that's called the Van Wyck-Grumbach syndrome, simply on the basis of hypothyroidism. And this is partly because of the alpha subunit being similar, and also because of the hyperprolactinemia. Anemia can happen in women because of hypothyroidism, and it can be a pernicious B12 deficiency, or it can be iron deficiency from having menorrhagia that's very common in women with hypothyroidism. And it can cause subfertility and infertility. It can be a cause of recurrent pregnancy losses, and of course can induce gestational hypertension and gestational diabetes. So as something which we think is simple, like hypothyroidism and subclinical hypothyroidism, has far-reaching effect on women when compared to men. Now, coming to obesity and eating disorders, we just know that this problem is much bigger in women. And this has been shown in studies done in Chennai by Dr. Vijay Vishwanathan. Both children, adolescents, adults at every level, girls and women were higher. We know from the INDIAB study, both generalized obesity and visceral adiposity are higher in women. And in this study from the MENA region, we can see that the increase in obesity in women from 1990 to 2016, how it is rising. The biggest challenge for about obesity in women seems to be physical inactivity, not just not just a nutritional issue, which may be in certain societies where either women eat leftovers or women eat late, or women do not get much fruit and vegetables and tend to eat a carb-rich diet. or may not be getting the high protein diet. But I think it boils down largely to physical inactivity. Having said that, the life cycle of women at puberty, during pregnancy, during lactation, and menopause, there are opportunities for weight gain. And the weight, not only the weight gain, but the weight distribution is different in women. We know that there is a gynoid kind of obesity where the weight is more in the hips and in the bottom. And the male pattern obesity tends to happen in women, a redistribution after the menopause. But one area I think we as physicians can focus on in women is the post-gestational weight gain, both gestational weight gain and post-pregnancy weight gain. As you can see, the first pregnancy, the gestational weight gain leads to higher BMI, fat mass, and visceral fat. But if they don't work on this postpartum, then some of it remains. And then in the second pregnancy, they accrue some more. And all of this later in life leads to higher BMI and higher risk of type 2 diabetes, cardiovascular disease, and other complications. So this may be one low-hanging fruit that we can approach from a gender medicine point of view. And also we need to, you can see that there is a difference when babies are born low birth weight. We're not just talking about high weight, also low birth weight and thin body stature. You can see when the birth weight is low, if the mother is undernourished, we talked so far about obesity. If she's undernourished and gives birth to a low birth weight baby, then there is also not just increased risk of type 2 diabetes and metabolic syndrome, also increased risk of gestational diabetes. And I know that Anuj will agree with me that we all now believe that GDM is the mother of future NCDs. What about osteoporosis and vitamin D deficiency? Again, we know that women have a much higher risk of osteoporosis, bone loss, and fractures than men. And this is because of this. This cartoon very nicely shows us women have a lower peak bone mass. They have life events like pregnancy and lactation where their bone mineralization may be affected. But most importantly, they have this phase in their life called menopause when there is an acute drop in the bone. There is much greater bone loss in a 5-10 year period. They lose so much bone, and because of that quickly go below the threshold for fractures, and therefore they fracture much earlier. And we now know that diabetes itself is a high risk factor for fractures in women. The INDIAB study actually showed that it is exclusively in women the fractures are happening, those with diabetes, though global data has shown both in men and women obviously much more. And therefore we need to pay attention to women's bone health from calcium supplementation, optimizing their vitamin D, promoting sun exposure, promoting physical activity, good nutrition, and addressing their bone health either by doing BMD or FRAX and initiating treatment, and educating our seniors on fall prevention. Because as you can see, low peak bone mass, what can we do about it? Making sure children and adolescents get good nutrition, sun exposure, and their health is good. Propensity to fall, all of those we have to fix, vision and coordination and avoiding hypoglycemia and the postmenopausal bone loss. We can't do much about that except that we can make sure that their calcium, vitamin D nutrition is good and address risk factors like smoking, alcohol, and coffee, and thin stature and things like that. But most importantly, also, we need to screen for osteoporosis at the right time. And I think in India, at least I am recommending that we start screening women 5 years after menopause or 55, whichever comes first. Very, very important. One more thing that happens to women when menopause happens, and the age at menopause has remained the same around 47 to 50, whereas female life expectancy has gone up tremendously. So women are spending a lot of time after the menopause. So we need to make sure that they are their bone health and other things are good because of many years they are living after the menopause. I've pretty much come to the end of my talk. I just want to mention one important area that I think we are overlooking in women, which is pre-diabetes. And you can see from this study, the CAR study, Chennai, Delhi, Karachi, everywhere, higher amount of pre-diabetes in women, which is predisposing them to heart disease and diabetes and other complications. So very important that we address women's health, address endocrine and metabolic diseases through the gender lens, and address women, especially preconception, because pregnancy now seems to be the window to future chronic disease, and addressing their health prior to pregnancy and during pregnancy, I think is going to give us a lot of benefit throughout their life. Thank you so much for patient listening.
Thank you so much, Dr. Usha, for such a prolific talk on viewing various medical health through the gender lens. And as rightly said, that gender is unique to humans. Animals don't have, we don't talk about gender in animals, it's just the biological sex. And you have beautifully elucidated the effect of COVID on, how it has widened the gender gap, and it has pushed women towards poverty and poor health. And you have nicely depicted the inherent differences in terms of whether it's a diabetes or thyroid disorders or obesity or osteoporosis and vitamin D deficiencies. And we need to look into these problems. We should look into the equity that they get better services, health services to overcome these problems. Thank you so much, Dr. Usha, and question answers would be taken up at the end of the third session. So over to Dr. Sharma, please.
Thank you, Dr. Padma, and thank you, Dr. Usha. Wonderful talk. Now, please stay with us because we will have the question answers at the end, both of you. Now I invite Dr. Jalis Fatima, Professor of Medicine at Lucknow Medical College, and she is the Fellow of American College of Physicians, and she is also the Treasurer of American College of Physicians India chapter. So she will introduce Dr. Vinod Ravindran for the next talk. So over to Dr. Jalis Fatima, please.
Thank you very much, sir. And it's my privilege to introduce Dr. Vinod Ravindran, who is MD FRCP and a senior consultant rheumatologist in the Center of Rheumatology, Calicut, Kerala. He is the adjunct professor of medicine, KMC Manipal. And he has rheumatology training at London with certificate of specialist training in rheumatology, MSc rheumatology and MRCP in rheumatology. He is elected FRCP Edinburgh in 2011. He has got special interest in rheumatoid arthritis, and his publications are more than 100 and several chapters in the books. He has written the books and abstracts in several books and abstracts in several journals, and has got several awards in his name. He is editor-in-chief of the Journal of the Royal College of Physicians of Edinburgh, associate editor of Rheumatology, Oxford, regional advisor, South India, the Royal College of Physicians of Edinburgh, UK. He is a secretary-elect of the Indian Rheumatology Association and international examiner of MRCP. He is the past editor-in-chief of Indian Journal of Rheumatology and the past executive committee member of Indian Rheumatology Association. So I invite Dr. Vinod Ravindran, and it's my privilege because he is a name in the field of rheumatology and the autoimmune disorders. We all know that it's a spectrum of disorders which has its effects in all the ages. Some of the diseases in the autoimmune disorders, they affect the younger age group predominantly, and some affect the later age, like if we talk about the gender equalities and the gender differences, and with these implications, what is the impact of these phases of life, especially in women when they pass through their lives of the reproductive age and that of the menopause, which the earlier speaker was also speaking upon. So these diseases also, they are very, very important to be discussed with in terms of the gender differences, how the disease burden differs, how the quality of life differs in both the genders, how the disabilities and the treatment and the response to treatment and seeking of treatment differs between the two genders, and how the different phases of life, they require the different kind of treatment in both the genders. So I think Dr. Vinod Ravindran will be the most important person and aptly telling about these aspects of the diseases, the autoimmune diseases, to us. Over to Dr. Vinod Ravindran.
Thank you for the very kind introduction. Can you, so that I can start sharing my, yeah, okay.
Yes, sir. Please try.
So, yeah. So thanks for the kind introduction. Only one correction, that I'm no longer the editor-in-chief of the Royal College Journal, but my other academic commitments continue. Okay, so these are the 3 journals. Look them up and please sort of think about considering your relevant work to these journals. Would be grateful. So the brief today for me is to talk about gender differences in autoimmune rheumatic diseases. And as speakers before me, and in the introduction and the preamble, Dr. Maheshwari and Dr. Sharma talked about gender differences or the relevance of gender differences in many diseases, including autoimmune rheumatic diseases, have come to the fore now. And everybody who's practicing rheumatology, musculoskeletal medicine, should be aware that what are the implications. So I will just start with a small quiz question for the delegates. And the question is, what proportion of patients are women in a typical rheumatology clinic? And the answers are 20%, 50%, 70%, and 100%. So before I reveal the sort of answer, once again, it is important to consider the terminologies of sex and gender. Sex is basically the biology, and along with the anatomical attributes of a particular sex, and which includes secondary sexual characteristics. As opposed to that, gender is basically socially constructed characteristics in either men or women, and it could be norms, roles, relationships, perceptions, and it is quite divergent from the biology. But when we consider medical literature, these terms are used synonymously, and in fact, they do mean the same. So with that, what I'll be discussing is, I will briefly discuss the science as regards to the gender differences in autoimmune rheumatic diseases. So I will talk in brief about incidence, the reasons, and the difference in expression. I will also touch upon the peculiar impact of autoimmune rheumatic diseases on pregnancy or vice versa. And lastly, the impact on individual society and on us as medical caregivers. So, so the answer to the quiz was 70%. So, and you can see that it is perhaps in rheumatology clinics, the second most highest number of women are managed. And of course, for all obvious reasons, the obstetrics is the specialty with 100%. So a substantial number of our patients are women. If you look at the female preponderance among autoimmune rheumatic diseases, you can see that at the very top you have lupus and Sjogren's syndrome, where you have substantial female preponderance. And then you have something like systemic sclerosis, rheumatoid arthritis, and antiphospholipid antibody syndrome. On the other end, you have disease such as ankylosing spondylitis, which is basically has much more male preponderance. What it means that a substantial number of women are being affected by these diseases, and these women are being represented in our clinical workload on a daily basis. And that's why I think this is important. Now, what happens is, as most of these diseases happen to sort of younger women or in the middle age, this gender representation gets corrected as the age advances. And in most of the diseases, such as rheumatoid arthritis, once you are in the 7th decade of life, the preponderance is actually equal. There is no preponderance. And what I've shown in the previous slide, the table, is actually universal, and it is across all the geographical areas, countries, and ethnicities. So it is not to say that in some population it is, there is a larger skew. It is not the case. So if we consider the basis of this, there are 4 things we can consider: autoimmunity, genetics, sex hormones, and of course the gut microbiota. And I will also, as I said, I will touch upon the implications of pregnancy in terms of our knowledge, how the gender or how the female gender is affected in a peculiar way. So the first thing is the immune autoreactivity. In women, everything which is related to immune system is at a higher level. So the antigen presenting capacity is much more. The response to the immunological challenges is much more robust. If you compare the antibody production as a result of an immunological challenge, which is much higher, which could be measured and has been measured both in animal models and in human beings. And if you consider the graft versus host disease or the homograft rejection rates, it is much higher in females because they appear to mount a more sort of, a strong response as far as any immunological challenge is concerned. In males, on the other hand, they are more prone to infections. So the deal is basically either you have more autoreactivity and be prone to more autoimmune rheumatic diseases, or you have more chances of nasty infections, but be protected relatively from the autoimmune rheumatic diseases. So this is the sort of the whole thing which goes on in the female gender. If we consider genetics, so you have XX chromosome and XY chromosome. So it is the extra X chromosomes in women, which is a problem as far as the immunological response or the predisposition to several diseases is concerned. Because several genes which code for proteins such as I mentioned here, the TLR7, TLR8, the pattern recognition receptors, cytokine receptors, transcription factors, they are all encoded in the X chromosomes. So having one extra chromosome makes female gender much more susceptible to autoimmune rheumatic diseases. Nature has provided us models where we could consider these influences in a bit more detail. So, for example, in Turner syndrome, you know that it is there is no Y chromosome, so it is actually only one X chromosome. So the extra X is not there, So what do you see is you see much lower level of immunological response, immunological sort of components of the immune cascade among several sort of diseases. And they have, because of this, they have increased susceptibility to autoimmune rheumatic disease compared to the female controls. And this is particularly true in diseases where there is a proven male preponderance. On the other hand, we have another disease in the nature, or a condition in the nature, Klinefelter syndrome, where you have extra X chromosome, or you have, you can say that you have an extra Y chromosome here. Okay, so here you have lower testosterone levels, increased gonadotropins, high estrogen concentrations, and though these patients are immunological similar to females, as regards to higher immunoglobulins levels and higher response to sort of immunological challenges, there is a multifold increase in the prevalence of certain autoimmune diseases compared to the general male population in people who have Klinefelter syndrome. So the question must be asked, if X chromosome is a problem, what does nature do to dampen it down? So during embryogenesis, this extra X chromosome is actually silenced, or there is an attempt to silence it. But as it happens that nobody is perfect, this mechanism is not 100%, and about 15% of the genes escape this inactivation. And among this 15%, the further 10% of it will be spared differentially from this inactivation. So what will happen is that within, let's say, a cohort of female population, you will have women who have a higher proportion of X chromosome linked genes which has escaped inactivation. And this is going to make them prone to autoimmune rheumatic diseases compared to the healthy controls. Then if you are talking about gender, female gender linked to the hormones. So the two predominant hormones as far as the male gender is concerned, testosterone and progesterone, they have overall immunosuppressive effect. Whereas estrogen and prolactin, they have effect in terms of increasing the autoreactivity, providing more immunity. And primarily it is seen that the helper cell, the T helper cells, so we want to launch immunological response, we want more Th2 helper cells compared to the Th1 helper cells. So estrogen will increase the concentration of Th2 cells, which we need, and androgen will favor the development of Th1 response, which we don't want. And this is sort of a slide which tells us that at the higher concentrations, what you see in pregnancy, the estrogens can launch an immune response which is actually favorable to maintenance of the pregnancy, whereas estrogens in lower concentration can actually favor the onset of or the severity or the expression of the autoimmune rheumatic diseases. Androgen, as said, has got basically immunosuppressive effect, but again, depending on the disease, the expression of both androgens and progesterone can be different. But you can see at a glance that the hormones are linked with either directly or indirectly to several different components of the immunological cascade. And finally, when we talk about the reasons, there is gut microbiota, which is gaining a lot of attention nowadays in many diseases, many autoimmune rheumatic diseases. And in the mice model, certainly it has been seen that if you get rid of the gut microbiota, in the such germ-free mice, in both male and female mice, the expression of certain diseases are going to be different. Like, for example, that there is increased sensitivity to develop type 1 diabetes in female mice and not in male mice. But the other fact is that at the puberty, there is a divergence of this microbiota. Linked to that is the concept of can a gut microbiota could be transplanted in individuals who are suffering from autoimmune rheumatic disease. And the basis is that actually it has been seen in the mice model that the protection is lost among the germ-free male mice as they grow older, and also with the puberty, the protective effect of such gut microbiota can be transferred from male mice to female mice. So in summary, these are the four things. So we got genes, we got hormones, we got X chromosome, and then we got possible role of microbiota, which explains the female preponderance in several autoimmune rheumatic diseases. And possibly this is the explanation of varied disease expression, what we see. I will tell you that. But before that, I'll come to the implications of pregnancy. Pregnancy and autoimmune rheumatic diseases have got a complex relationship. While some diseases have got very high risk, in some the risk is not that much, but it can happen it can develop during the pregnancy for the first time, or a pre-existing disease can flare up or express itself differentially or differently during the pregnancy. If you simply consider immunology of pregnancy, the fetus is considered a semi-autograft, allograft. Half of the genetic material is from the father and half is from the mother. What is from the mother is not a problem. What is from the father is considered graft. So simply putting, similar to a graft versus host phenomenon is going to take place, and the embryo would be rejected unless the maternal immune defense systems are not activated. So in autoimmune rheumatic diseases, especially in SLE, this maternal immune responses are not that robust, and that is linked to the frequent pregnancy losses. And I have talked about the T regulator cells, T helper cells. So you need both T regulator cells, T helper cells, and in T helper cells you need more of Th2 cells, less of Th1 cells. And for a disease to be manifest during the pregnancy, in terms of severity or adverse pregnancy related outcomes, this balance is altered. So what we know that in several autoimmune diseases like lupus, there are a lot of problems. Some of the other diseases, we used to think that actually they don't impact the pregnancy that much, but that is not true. But further discussion is beyond the scope of this talk, so I will skip that, except to just show you that in a disease like SLE, just look at the factors which come into play during the preconception, before becoming pregnant, during the pregnancy, and after the baby has born. You have disease activity to consider on one hand, the drugs you are going to use, the specific autoimmune antibodies, ROLA, antiphospholipid antibodies. Then even whatever, the irrespective of the outcome of this pregnancy, what will happen to the next pregnancy, what will happen to the breastfeeding. So the problems are really that many when it comes to lupus in women. When we consider the fact that, okay, there is a gender preponderance, male or female, but is that really translates to a difference in the disease expression in some of the rheumatic diseases? So I have chosen 4 for you. Rheumatoid arthritis, you know that this is the male to female ratio, 3:1. Unfortunately, the disease is equally severe at the time of diagnosis, but somehow in the older studies, the men were more likely to achieve remission, and it was thought that possibly it implies that they have a better response to the existing therapy. But the recent studies have not actually substantiated that. For all practical purposes, in terms of disease expression, disease severity, and the treatment response, in rheumatoid arthritis at least, everything is similar. When you consider a lupus, where you have a disease preponderance, 9:1, you have some of the features which are quite common among both gender. But of course, in male, you have more severe renal and cardiorespiratory involvement, whereas arthritis is more common in female. When you consider systemic sclerosis, and again, you have in women, younger age of outset, you have limited cutaneous type of disease, and survival is better, whereas in males, age of onset is much later. They would be generally cigarette smokers, a diffuse involvement, and poor prognosis is much more common among males. The systemic sclerosis is often seen with overlap syndromes, and female, the commonest overlap is with SLE, where in males it is most common with myositis. So that is some of the differences. When it comes to spondyloarthritis, I have chosen this because this is a disease where you have male preponderance. So it is interesting to see whether this disease is expressed differentially or differently in women compared to men. If you look at HLA-B27 positivity and any positive imaging at any time during the disease course, it is much higher among male. So that tells you that you have a problematic gene much more commonly present. And of course, you have radiological evidence of such involvement much more commonly in male. When it comes to the clinical disease, there are a few things which are much more common in females, such as pelvic pain, heel pain, and they report widespread pain much more commonly than male. And there are some things which obviously confound the whole perception of the pain, such as depression, coexisting fibromyalgia. But when you look at the hardcore sort of rheumatological expression, enthesitis is much more common in female. The inflammatory bowel diseases is much more common in female. Peripheral arthritis is much more seen in female gender. So these are some of the differences, clinical differences you might be able to appreciate. Now I come to the last part of my talk. Okay, so it is agreed that there is predominantly a female preponderance among many autoimmune rheumatic diseases. We had talked about the possible reasons of having that the case. Then we have considered that how in some diseases the expression is different. But fortunately, these differences does not sort of, impacts on the treatment or the treatment response. But how it impacts us is when we consider everything in the Indian context. I had talked about lupus pregnancy at some length. When you consider lupus pregnancies in India, the challenges are just too many. So we have something like unplanned pregnancies, delayed in diagnosis of the lupus, delayed referral to rheumatologists. As it was said during the introduction that in our societies, somehow the attention to a female or disease with female or female with disease is not as equal to men counterparts. So this leads to a lot of sort of trial with alternative therapies. use of over-the-counter medication, referral of the appropriate consultation, poor adherence to the treatment, and we know that whenever pregnancy is unplanned and adherence is poor and the disease is active, the pregnancy-related outcome is going to be universally poor among women with SLE in India or anywhere else. Then, because of the female preponderance, if the clinicians, people who are interested in rheumatology, are not attuned to the idea that sexual dysfunction is widely prevalent in rheumatic diseases, the exploration will not take place. So one of the barriers is basically the gender of the patient. And this barrier, so we have to consider that the 70% of our patients are likely to be women, and a proportion of them might be having sexual dysfunction. So whether it is a male clinician, female patient, or female clinician and female patient, or vice versa, these are real challenges in communication.
So, Dr. Ravindran, we
Just
are
last 2 slides, ma'am.
lagging behind.
So yeah. So there are a lot of sort of specific requirements as far as women are concerned from India, and I will just show you few slides related to the day-to-day activities of female in India. So you know all this, okay, right from cooking, grinding, pounding, cutting vegetables, you name it. This is a daily challenge for somebody who has, let's say, for example, arthritis. And some of these activities are not done just for the home. This could be a small-scale industry for a woman to earn livelihood for the whole family. So the question is asked, why the pictures you have shown, they belong to rural India. But the fact of the matter is, actually, the India truly lives in villages. And these are the patients we see in our clinic every single day. So, and of course, the expectations are much more. I mean, I would not bore you with that. But the realities are painful. So the financial condition of the husband impacts on the overall support to the management. And in terms of management, necessary healthcare, they are not given the same priority as male. And with the advancing disease, everything becomes very, very difficult for these women. Compared to the developed countries, I think you have realized that our challenges are much more difficult and they are unique. So I think sensitization is one thing, appropriate knowledge is another thing, and where possible, developing a framework where you can offer slightly more support to these patients is very, very important. And I have touched upon that, and I just leave you with this thought that imagine that this is, we all want to do a namaskar, and imagine that this is sort of, what they are not able to do. We see this type of patients every single day. We have therapies, we have diagnostic tools, but when the patients come to at this stage, we have to look what were the reasons why they have come to this stage. And I think the answer lies in how our society deals with. Thank you.
Thank you very much, sir, for giving this explicit account of the rheumatological diseases and what may be the possible reasons for these gender differences in rheumatological diseases. What are the basis of maybe the genetics or the hormonal reasons or the gut microbiota, and what are the impacts on the social life of a woman and men also. So we will be discussing this later on, I think, in the panel discussion. I hand over to Dr. Jk Sharma, sir.
Thank you, madam. Thank you, Dr. Jalise. And thank you, Dr. Vinod, for the wonderful talk. And please stay with us. We will have the question answers at the end. And for the last talk of today, I invite Dr. Divya Saxena to chair this important session of Dr. S. Santakumari. Dr. Divya Saxena is Senior Consultant Physician Diabetologist at Sonipat, and he is a leading person in the Indian Medical Association, and she is taking the health program of IMA further. I request everyone who is not talking to please mute themselves. And Dr. Divya Saxena is an important person when we talk of our women physicians, because she is leading the brigade in this. And I'm thankful to Dr. Anuj Maheshwari for trying to equalize the gender inequality in this particular webinar, because out of the 8 faculty involved, 5 are female physicians or the women physicians or the women. So over to Dr. Divya, please.
Thank you so much, sir, for the kind introduction, and a very good evening to all of you, to all the esteemed guests and the speakers of today's program. At the outset, I must thank Dr. Anuj Maheshwari and Dr. Jk Sharma, sir, for giving me this opportunity to be an important part of this very important discussion going on in today's event. So, actually, we are going to talk about the violence against women. And what do we understand by this term is that it is defined as any act of gender-based violence that results in or is likely to result in physical, sexual, or mental harm or suffering to a woman. Particularly, we know that intimate partners violence and sexual violence is a major public health problem and a violation of women's human right as well. So we know and we want to discuss and we want to talk about today that this violence against women is really preventable. And as a health sector, which we have an important role to play to provide comprehensive health care to women subjected to violence, and as an entry point for referring women to other support services they really need. A women's right to live free from violence is upheld by so many organizations, and we also are going to talk about this. And we cannot find the better day to talk about the very important subject than the eve of the National Girl Child Day, which is celebrated on 24th January every year, as to create awareness about the right of the girl child, the importance of girls' education, and the health of a girl child. And to discuss about the subject, we have among all of us Dr. Shanta Kumari ma'am, who was leading the organization, the biggest organization having the maximum number of female doctors, that is FOXY. So ma'am has so many awards in her accolades. She is FRCOG UK 2018. She is FRCPI of the Royal College of Physicians of Ireland. She has initiated DHERA 2016, a social medical campaign to eliminate violence against women. She has a Lifetime Achievement Award in her name, 2020 OGSH, 2021 MOGS, Dr. Ganatra Charitable Medical Center Award, 2020 MOGS, Mr. N.A. Pandit and Mrs. Shailaja N. Pandit Award. She has the Pride of Foxy Award 2019 also in her kitty. She was also awarded as Foxy Star Award 2017. She was a Young Scientist Awardee at National IHR 1997, CL Jhaveri Award at 42nd AICOG 1998, and she has delivered so many orations. So I would invite ma'am to please deliver your lecture on this subject, that is violence against women. Over to you, ma'am, for your deliberation.
Yeah. Good evening, everyone. At the outset, I would like to thank. Thank you, Dr. 1 minute. I think there's something which is. 1 second. There is. What is this? Good evening, everyone. I would like to thank Dr. Anuj for inviting me to join this platform of the American College of Physicians India chapter. Thank you, Dr. Divya, for the kind introduction. Well, aptly said, Dr. Divya, we need to talk about why no to violence against women. Why is it that we as healthcare professionals, especially we as
Sorry to interrupt you, but
Yes.
your slides are not visible.
Not visible? Oh,
No.
there is.
Whenever your screen share, there was one option.
Second, I know that there was.
Okay.
Because now day in and day out we do only that, no?
Yes, ma'am.
Just hold on 2 minutes. I don't know why this is. Something has happened to the screen.
मैम
Now?
मैम आपका पीपीटी बैक मतलब पीछे ओपन है क्या?
हाँ अभी ओपन किया ना.
ओके मैम. सो आप ग्रीन कलर के आइकन पे जब क्लिक करें तो आपको क्या ऑप्शन आ रहा है वो स्क्रीन शेयर के टाइम पे?
एक दो बार आ रहा है. अभी स्क्रीन शेयर ऑप्शन कर रहा हूँ.
आप स्क्रीन शेयर कीजिए.
हाँ करिए.
मैम नहीं, आप जब भी ग्रीन कलर के आइकन पे एक बार क्लिक कर रहे हैं ना तो आपको मल्टीपल्स ऑप्शन आएंगे जहाँ पे आपको आपका पीपीटी भी दिखाई देगा.
वो पीपीटी नहीं दिखाई दे रहे आज. That's why I'm also wondering why this has happened now.
So if possible, kindly mail your PPT on my mail ID. So I will share it from mine.
Can you just give 1 minute? I'll just.
Okay, no problem, ma'am.
No issues, ma'am. Take your time, please.
Can you see now?
Yes, ma'am.
Yes, ma'am.
Yeah, thank you. Thank you for telling me that that screen was not seen. I think when we talk about no to violence against women, even the screen is a little upset that we are not given as much importance to this topic as needed. Friends, I bring greetings from Foxy, the 38,000 strong body of OB-GYNs as the President Foxy, and I'm the treasurer of FIGO, the global voice of women's health. When you look over the history, when you're talking about women's health, now what has changed over the times, right from the time of Mahabharata to Hatras and today? Nothing much, unfortunately. Still, the woman is facing so many issues which ought not to happen. When you look at statistics, look at these statistics. And this shows how widely violence against women is there across the length and breadth of our country. Friends, unsafe spaces, when you look at it, we find that there is no place which is safe for a woman to be around. And that is so very disturbing. And to understand the widespread manners of violence against women and how it intersects with the health issues in women, and we need to focus on the impact of violence against women during pregnancy and the role of OB-GYNs in detecting violence. And of course, we need to see how the role of trainees has to be there to focus on violence against women as the future torchbearers of women's health. In fact, way back in 2013, we initiated Save the Girl Child to prevent female feticide and to create awareness in the society. Violence against women is perhaps the most shameful human rights violation, perhaps the most pervasive. It knows no boundaries of geography, culture, or wealth. As long as it continues, we cannot claim to be making real progress towards equality, development, and peace. So said by Kofi Annan, and so very true even to date. any behavior causing physical, sexual, psychological, and reproductive coercion, forcing a woman to live in fear. That is violence against women. And unfortunately, in the silent pandemic of violence against women has emerged as a major pandemic in the COVID pandemic situation today. What is it which we can define as violence against women? Right from forced pregnancies to forced abortions to forced sterilizations to denial of family plan. When it comes to women's right, who is it that who is going to decide when the woman is ready to have a pregnancy, when the woman wants contraception, or when she would like to have an abortion? Is it going to be the family? Is it going to be the mother or the mother-in-law or the husband or the government? Friends, it should be the woman who has to decide her sexual and reproductive rights. And unfortunately, reproductive coercion is a norm rather than an exception. And Indian data shows it's prevalent from almost 22% to about 50%. And when you look globally, unfortunately, the violence against women has got no barriers. It is there in all parts of the globe, right? From the very developed to the developing to the underdeveloped. That's only one area where there is universal presence of this problem. And look at the global burden of disease. Look at what WHO says, that when you look at the intimate partner violence, 35% of women, and in Southeast Asia, it's about 38%. And the studies which were there in 2002 to 1999 are the same when you look at 2013 statistics. Look at statistics in India, nothing much to be proud about. Crime against women, 1 in 3 minutes, 1 rape every 29 minutes, and 1 dowry death, rural women more affected. India has the highest rate of violence during pregnancy. The so-called developed areas, look at all this. Everywhere it is there, irrespective of the place on this globe, the prevalence of intimate partner violence and domestic violence, friends. Unfortunately, India is also among the top 15 countries with global high levels of intimate partner violence. And when you look at this chart, look at all the different types of abuse, be it the child marriages, the girl-child abuse, to excess female child mortality, trafficking, custodial violence, honor killing, sexual harassment, and whatnot. Friends, this is something which we find is omnipresent. And reasons are so very simple, sometimes like burning the food, not cooking food probably, and arguing with him. This shows that men and women inequality, but endowed with the same dignity, is what we should look at. We find that in this COVID times, there has been a horrifying global surge in domestic violence reported globally. And that's the reason now everyone is taking note of this issue of shadow pandemic in today's world. When we look at our own statistics, I'm very proud of my state, but unfortunately, the prevalence of violence against women is at par at the global statistics. So to be born as a girl discriminated from womb to tomb, right from the pre-birth types of violence, sexual active abortion, effect of battery on pregnancy and childbirth, to female infanticide, to sexual psychological abuse, to child marriages, female genital mutilation, incest, pornography, and going on to be the courtship violence, dating violence, the cyber violence, trafficking women, so many different types of violences which ought to be actually put to an end. We as obstetricians find that physical violence in pregnancy is also there. We may mistake this patient as a near-miss mortality, but then when you go into the history, the patient will present with an antepartum hemorrhage, shock placenta accreta, vulval hematoma. And when you go into the history, it was for not willing for sexual life. And this resulted in the violence by the husband. There is hidden violence masquerading as maternal disorder, sometimes death due to eclampsia. But when you go into the history, sometimes direct death due to violence, where there was a fracture of the skull. So these are what we see as a rupture of the uterus is a result of violence kicking on the abdomen and effect of intimate partner violence. Friends, that is the reason why We need to look at the physical health markers. When patient repeatedly comes to you with maybe pain abdomen or some burning micturition, when you don't find any physical, look at it, what is it behind? They may come with history of fear, shock. Look at the psychological health markers. Look at the apathy, denial. All this will have to be actually dealt with. Violence in women's health, where do they intersect? Women are not dying because of a disease we can't treat. They're dying because societies have yet to make the decision that their lives are worth saving. Said by Mohammad Fathallah, who was the president of FIGO in 1997. Unfortunately, till to date, we are using this quote of his. So friends, I started the Dhira initiative when I became a member of FIGO, No to Violence Against Women working group in 2015. In 2016, I started this advocacy, the Dhira initiative, and thought that we need to look into what is behind the causes of maternal death. So you need to beware, be alert to the intimate partner violence. You can't talk about HIV unless you address this violence against women, because women are at more risk because men refuse to use condoms. There are studies which have quoted this. And violence is the root cause of us not being able to reach the MDG goals. And if we don't address this, we may not be able to reach the SDG goals also. We know that it's a well-recognized public health problem, a human rights violation. Friends, that was the reason why we actually decided to go ahead and start this Dhira initiative, because we obstetricians and gynecologists are in a unique position, specialist stakeholders in women's health, because of the nature of the patient physical and the physician relationship. Dhira means courage. The objective was to sensitize, advocacy, giving a call, focus on action, bring all the stakeholders, the police, obstetricians, women, men, NGOs as partners, the students and youngsters on one platform. Friends, we started this in 2016 with a public forum with the National Commission of Women, the SHE teams, the police, and the public and the OB-GYNs, and giving a call, asking to end this. We brought celebrities because we wanted this to be given media coverage. Media doesn't come only when obstetrician or a physician is talking. They need some excitement. That's the reason why you need to do public forum, to attract these people, because social media and media is print media is a powerful tool to send across this message. UN has identified orange color to say no to violence against women. So wear orange and say no to war. Friends, over the years, we have done cyclothons, bikeathons in various congresses with these flash mobs. The FIGO was there. And we say, partner with men to say no to violence against women. In fact, the terminology is going to get a change. We shouldn't be talking about violence against women. It should be violence by men. Why are we again targeting the word woman when we're talking about no to violence against women? So that is what needs to be changed. So friends, when we raised the voice of Dhira, we decided that we need to take it globally. 2017, we took it globally to FLASOC conference, where the Latin American societies were together. And then I realized at that point that violence against women is there across every part of the globe. And in fact, we in India are much better than women in many parts across the globe. Friends, here we made a press meet and we had to insist on a FIGO participation on no to violence against women. At the FIGO Congress in 2018, a declaration was signed by FIGO, UNFPA, WHO, and member countries to stop violence against women. This was a place where we actually did the march, no to violence against women, Dhira. Again, we actually received a lot of opposition saying it will become political, you can't use this. Then we had to put our foot down and say FIGO is the global voice of women. Globally, everyone is looking at us, at what we have to say to take care of our women. We are going to put our foot down and say everyone needs to stop violence against women. That's how we could do this Dhira in Brazil. And world over, all societies came to partner with us to say no to violence against women in Brazil. And this received wide media coverage too. Friends, we continue doing this Dhira, and so many times we find that in these today's date, where we find the COVID has really shown that a lot of issues are there, we have found that the WHO and all the other organizations have come out with very exclusive recommendations how we can address these issues. So when I took over as the president of FOXI last year, I decided I think we need to do something to sensitize the young brains. So I started this Dhira No to Violence Against Women online certification course, because what we need to target is we need to catch them young. We need to catch the boys and girls when they're young. So we started this new online certification course with UNICEF India. Now, this is a small 2-hour course which will talk about how violence is affecting the women's health and how it affects the country's health. And this is with the idea that we want to engage the government, the Ministry of Health and Family Welfare and Child Development, to make it a mandatory compulsory curriculum, because I don't want any boy who's seen his father or somebody doing violence grow up thinking it's okay to do violence. And I don't want any girl who sees her mother or somebody getting affected by violence grow up thinking it is okay, I have to accept it. We need to make them more gender neutral, and that is the way forward. Friends, I'm very happy to say that this online certification course is quite successful. We have trained 500 master trainers. We have enrolled almost 800 schools. Our target is to reach almost 30,000 school children. And we are going very strong with this project, because I've got 262 societies in the country with president secretaries and 38,000 strong gynecologists who are all well connected in their own places. And hopefully by the year end, we will be able to cover more than what I have promised, because that is the only way forward to actually show that we care for our women and mothers. Of course, workshops and CMEs for gynecologists and friends, violence against women to be detected in pregnancy, because it has an effect on women's maternal mortality rate. And obstetrician gynecologists can play a pivotal role in stopping violence against women by being their voice, screening for violence at every opportunity, providing healthcare and other possible health and support. Because a woman comes to an OB-GYN and not to the police or a lawyer at the first instance. That is the reason why we need to actually sensitize our own members to come forward and help the women who comes to us. The journey of Dhira should never end, because the courage should not end. It should be the violence which is affected against women should end. Let's hope that we actually grow into a society which is more gender neutral and gender sensitive. Thank you very much.
Thank you so much, ma'am. And very rightly said that nothing must has changed from the time of Mahabharata. And very truly said, ma'am, that we should change the terminology from violence against women to the violence by women. And there is a lot of things we came to know from you, ma'am, that your dedication, your immense work towards the rights of women. Thank you so much for making all of us aware of about Dhira and so many work done for the rights of women. And we know that at least 155 countries have passed laws on domestic violence and 140 have legislations on sexual harassment in the workplace. But the challenge remains in enforcing these laws, in limiting women and girls' access to safety and justice. And for this, we all have to join hands and we all have to work. We know that only limited percentage of women seek help for any sort after experiencing violence. And so we advocate for and support women and girls' access to quality, multi-sectorial services essential for their safety, protection, and recovery. Because the prevention is the only way we can stop violence against women. Thank you once again, ma'am, for giving us a motive. Thank you, ma'am.
There was a comment in the chat box about the transgender. Absolutely right, Mr. Nirav. In fact, FIGO, being the treasurer of the FIGO, I'm the first Indian to represent India on the FIGO board as a treasurer globally. We are actually changing the terminology and we are addressing even that transgender category also. So thank you for bringing about that very important, relevant point.
Thank you, ma'am. Thank you for answering this question from the chat box. Thank you, ma'am, once again. And thank you, Dr. Jk Sharma, sir, again for giving me this opportunity. Over to you for the next session.
Thank you, Dr. Divya, and thank you, Dr. Shanta Kumari. Now, after this wonderful talk, this is open for question answers. And may I request Dr. Padmasri Gulati to start with the question answer sessions. Please unmute yourself.
So I have a question to Dr. Usha, ma'am. Ma'am, you spoke about gender inequality when we apply women's health lens to various endocrine and metabolic disorders like diabetes, thyroid, obesity, PCOS, and other conditions, osteoporosis and all. And all these problems are basically because of genetic and hormonal differences, right? So the manifestation of the disease is because of the sex differences, biological differences, and the response to these problems. When we talk about the response of the healthcare to these patients, then we could talk about gender bias. So shouldn't we call it sex inequality rather than gender inequality as far as the disease manifestations are concerned? Over to you, ma'am.
That's a great question, and not just about diabetes or any of the endocrine disorders. I think this applies to all of them, because while there are some hormonal, biological, and genetic differences, and I keep saying in all my public speaking that men and women are equal but not the same. There are huge differences. So, but the experiences that women have or men have with the condition that they have is very, very different. For example, I just want to say that, when a woman goes to the emergency room and complains of chest discomfort, more likely she'll be told that it is reflux or fibromyalgia or stress and sent home. And it's happened many times, and then they just go home and have an MI or a dissection of the aorta and die. And this has happened even to a physician at the Center for Disease Control, who after delivering a baby, a few days later went to the emergency room with a complaint and again was just said, new baby, you're stressed, you didn't sleep enough, and go home. So there is also this gender bias comes from many levels: the health system, the healthcare provider, how we are wired in our head about looking at men and women, and how women experience. For example, you just take diabetes. They may not be able to afford the medicines the doctor is prescribing. Nobody may be caring for her at home. She may be the caregiver for everyone else, but who's taking care of her? Who's going to take her to the hospital? And when she goes to the hospital and when she's prescribed medication, if it is something expensive, it may not be something that even her own family may get it for her. I'll give you an example from the endocrine point of view. Girls are brought to me with short stature just before they're ready for marriage. Or a PCOS girl is brought to me just before they're starting to look for a groom to make her lose weight. Whereas a boy would be brought to me at a much earlier age for short stature, because they're genuinely concerned about his height and what this could mean to him as future as an adult. So there are many inbuilt biases at many levels. So it's not while there are major biologic differences that cause the disease or how it is clinically presenting, but the experience that people have and how they are approached by the healthcare system, I think is really the biggest problem.
Rightly said, Dr. Usha, that we need to change the physician's approach towards female patients. We need to sensitize them that they need to, treat them. I mean, they should keep anxiety disorders as the first possibility in the differential diagnosis, and then way down comes the real organic problems. And we do come across these gender differences, in social life, which is very prevalent. Like females are often excluded from education. They're ignorant about health problems, how to prevent and how to receive treatment. And many a times they are subordinate to men, they are given distinct roles. I mean, their main role is in the domestic side, where they are the reproductive providers, as said by Dr. Sharma, and their nutrition is also, males are given preference, in especially in lower socioeconomic group. During the time when a girl is growing, during her adolescence, when her nutritional requirement is more, that is a time when they are being marginalized, and the major chunk of the nutrition of the food is being given to the men or the boys in the family, thinking they're going to be the bread earners. So we need to change, we need to sensitize the whole society in the whole, so that we can have gender equity rather than gender equality. Like Dr. Sharma said, that equity is need based. During the time when a girl is menstruating or she's undergoing pregnancy, that is a time when the demand is more. So we need to give them more rather than giving the whole society equal. So we should talk about gender equity rather than gender equality. Over to you, Dr. Sharma.
Thank you, Dr. Padma and Dr. Usha. Now, may I ask Dr. Divya to put two questions to our speakers, Dr. Shanta Kumari. Dr. Divya, are you there? Madam, I would like to ask one question to Dr. Shanta.
Yes, sir.
You are heading and leading a very important organization where I think the members are maximum number 38,000, and that too the women. So the women power of the country is there. So what Foxy is particularly doing for our country regarding this gender inequality, especially in reference to what you have told, but any specific project at the present time, which is all over the country?
Sir, I've just mentioned, in fact, we are 38,000 gynecologists. There are a lot of men also who are gynecologists. We are taking care of women's health. In fact, my teachers, all three teachers were men. So men are committed to women's health too as gynecologists. That's point number one. And then, yes, as Foxy president, I've initiated this DHERA initiative, which I initiated this in 2016 when I was the FIGO global group on working group on no to violence against women. This DHERA initiative was first started when I just mentioned that across all the conferences we were making the advocacy and awareness among our gynecologists, the police, the society, the students, everyone, that once you're talking about violence against women, then everyone knows that it's an issue, and those who are inflicting it also will be a little wary of doing it. And now we have started this DHERA online school certification course with the UNICEF India, and this is taken shape and it's been launched. Now many schools have been enrolled. Already 800 schools are enrolled, and we are targeting to actually do up to 3,000 schools. It may scale up to more than that. And this is a very important, because adolescent minds are young minds, and those are the minds which we need to address, because they will grow up into a more gender neutral society. And OB-GYNs, when they're more sensitized to this, they'll be able to pick up the problems when women come to them.
So thank you, but still more awareness amongst the people is required at the present time.
Yes, sir. Everyone needs to do their bit, right from the government to the celebrities to the society to all individuals at home, school, everywhere. Everyone needs to remember. The society has to accept that this is an issue. The societal change has to come. only then we'll be able to make it. Only an obstetrician gynecologist or proxy will not make a difference, but it's every individual who has to actually make their bit of contribution so that we don't need to talk about this in future.
Thank you. There is a question by Dr. Narsingh Verma, who is the secretary of our ACP India chapter. And this question I'm targeting to Dr. Vinod Ravindran because he has been there in UK also, and he has been the past editor-in-chief of the Journal of RCP, whether gender bias is ethically allowed.
Thank you, sir. I think that's, do you mean in the authorship or in their representation in the academics? Whatever it is not ethically allowed. It is unethical. People have to be appreciated and engaged with depending on their capabilities, their merit, their intentions and initiative. So, but there is literature. We also looked at the gender representation in Indian Rheumatology Association's annual meetings over the last 10 years, from 2010 to 2019. That's 10 years of our annual conferences. And, so ours is a sort of new society with 1,300 members only. Over the last, so in the second half of the study period, the enrollment of women members have been higher compared to the sort of, the historical cohort. But what we see is that, and this is true across all the medical specialties, except for maybe obstetrics and gynecology, and all the continents, that the numbers in as speakers, chairs, faculty in the medical conferences does not represent their true numbers as in their given specialty. And this is also true as far as the females as either the first author of an original article or an abstract is concerned. And this is also true across several specialties, including rheumatology. So I think the point is, though it is unethical, I think the sensitization and the engagement is less than optimum. There has been some positive trends as far as our own association is concerned, and this is also true in our European sort of society, which is the largest society, in the American College of Rheumatology also, that in the last 3, 4, 5 years, the gender representation in the academics has actually much more sort of, it's coming closer to what are the true numbers. So it goes both ways. And there is a mentorship role also. The women who are in leadership position, and this I speak from, my direct sort of observations, that women who are in the leadership position, they don't sort of seem to be that more sort of, engaged in terms of mentoring the female students. So there is a bias there also, and I think this is so. So women traditionally look up to women in their own specialty as the role models. So when the mentoring and support does not come from there, because of any reason, there is a disengagement and there is a disenchantment, and that leads to reduction in their appearances in the medical academic conferences. So they just stop going to the medical academic conferences because they have no role to play there. And whatever role they have, it is not representation, it is not representing their true worth in the society, academic society. So I think it is unethical, but it is there. And it is a challenging thing to sort of overcome.
May I add something, Dr. Sharma?
Yes, please.
I completely agree with Dr. Ravindran. I think it's time not just for gender neutrality, but actually a gender transformative approach. The gender transformative approach can come only if we do it with a lot of intention, meaning like today's conference, with every conference, every panel, every society, every department, that we look for equal representation. We may have to start out with more than 50% to ultimately for things to even out. So unless the playing field is leveled first for men and women, I mean, and it's going to take a while, then only then, this issue, we won't be talking about this, but we'll be talking about important things like how can we have gender-specific guidelines in healthcare, or how do we take care of trans women and violence against them. And one more point I wanted to add is Dr. Shanta Kumari's talk was amazing. And we are also recently, as an endocrinologist, what we're seeing is verbal abuse, mental abuse, emotional abuse is also violence. And that is actually impacting on pregnancy, and women are delivering low birth weight babies. So much so that stress is now being looked at as a teratogen. Maternal stress is being now looked at as a teratogen. So violence against women is not just beating up the women, but actually abusing them emotionally, which then will translate to not eating properly, not going for checkups. And I'm sure, Dr. Shanta Kumari and other OBGYNs are facing the brunt of that. Thank you, madam. It was an amazing talk that you gave, and a very important topic, which is actually the lid has been blown open by this pandemic.
Thank you. Thank you all. And now Dr. Anuj Maheshwari is with us, our governor. So I request Dr. Anuj to please.
In fact, I was very much here since from the very beginning, and all the talks were so nice and so innovative. Then even I could not keep my eyes away for a single second. So I have listened to all the talks very sincerely, and it was really innovative sessions, never heard before. Dr. Usha Shiram, as always, she is one of the most favorite speaker of mine. And whenever I get an opportunity to listen her, it's always a kind of the treat to me. And for the first time, I could listen Dr. Ravindran, Dr. Shanta Kumari. That's a fantastic. And more important thing is that we physicians should understand that what is the meaning of gender equality, and what is the meaning. Today, I think many of the physicians could understand what is the difference between social equality and biological equality. We were, as a physician, we were talking about the biological equality. We were talking about the hormonal imbalance. We were talking about the, as far as the cardiovascular outcome is concerned, men or women are not the same. But how do we treat them? This is really not talked much. I have also organized one program for that with the doctors in the medical profession, in which Dr. Usha Shiram was also there, and Dr. Sarita Bajaj was also there. And in that program also, we discussed that the things are really not being done as they should be, and somehow we have to change our attitude to look over the problems, to look over the diseases, and to treat the diseases. And probably American College of the Physicians is working in that direction. We are not really looking for and organizing the programs which are sellable, which are more popular for the industry. We are really organizing the program which are required by the society, which are really helping the society to make it more useful for the people. We are trying to make more useful our physician fraternity, our doctors fraternity, for the more useful for our society. Thank you very much for all being with us. Thanks, Dr. Usha Shiram. Thanks, Dr. Ravindran. Thanks, Dr. Shanta Kumari. And I can't forget our chairpersons. Thanks, Dr. Padma Shri Gulati. Wonderful questions you have designed, and you organized the first session in nicely. Dr. Jalis Fatima, always very terrific in her approach. And Dr. Divya Saxena, she has very nicely organized the session of Dr. Shanta Kumari. And finally Dr. Jk Sharma, who has given the insight of organizing this program. And I really give the credit of this to him. He gave this idea to my mind, and then we jointly organized all the topics, sessions, speakers, and finally we could reach to the day. And I believe that today will be remembered along in the ACP program, and many more programs we shall be organizing in the similar theme in the next near future. Thank you. Thank you all.
Thank you. Thank you, Dr. Anuj, for giving me the opportunity, and second, accepting my idea of this particular webinar of gender inequality. And you, as you said, it was innovative. I am the Secretary General of Innovative Physicians Forum. So thank you.
Always you are looking for the innovations.
Thank you
And
very
we
much.
also look for the innovations towards you.
Thank you very much. Thank you, everyone.
Thank you. Thank you.
Thank you. Thank you, everyone. And good night.